And again on a topic which is again, for which I have no clue, right? In India,
It's always pleasure to listen to you.
so in India, allocation is very simple, right? You have the organ and you take it, right? So there are no algorithms and there are no concerns. It's simple, somebody who's on the waiting list and you just get the organ. So when I asked to talk about it, I thought I probably should look into the world literature and with people sitting from all across the globe. The allocation policies, I found them very confusing, and I'm going to confuse you more than what I am. So, but why allocation rules matter is that I think one thing is that the paired organs, the kidney and pancreas, probably are better in terms of surviving patient survival. And then you have your waiting times, the ischemic times, the matching. So all those parameters put together, if you allocate, your outcomes are going to be better. So these are the principles which are used worldwide in one way or the other. So ABOI compatibility is a must, HLA matching, and then there are priority groups. So SPK always take a priority over PAK and PTA. Geography and travel, which makes the travel time longer or shorter, which leads to consideration of the ischemic insults. And then you have to have an equity so that it's a fairly distributed system which balances the best graft survival to the equal chance of getting an organ. So these are the basic principles which are there in all the systems, but each system is different. Their logarithms are, the scoring systems are different, but ultimately boils to the same thing. So I just thought that we are more, UK people are more popular with us. We are more close to them. So I thought probably have a look at the UK system. So please correct if there is anything wrong in my slides, right? So there are a lot of people sitting here. So I think the age of donors, so 61 years you take for DVD. Please correct if I'm wrong here, right? So that's I took from the NSB.
Absolutely correct. And you're right that in the UK, the pancreas and the islet patients share the same donor pool. So there are no separate.
Yeah. So in the US, that age is 50 years. So UK is probably more. There are more bold people there, and so they probably split this into three categories of urgency, that A, B, and C. So the A probably will get an earlier allocation, B at a second, and then the C ones. So these are the 7 elements which are being taken into account: the total HLA mismatch, the waiting time, sensitization, travel time, body mass index, whether patient is on dialysis or not, and differences in the age matching. So this is the complex part, right? I don't know why they give 730 points or something, right? Why can't they give 1, 2, and 3? Right. So this is different if you have a whole organ versus you have an islet cell. For waiting period, they that's probably equal to what we do. That one we give 1 point for every month, and they probably are looking at days. So 360 divided by 365. For sensitization again, and for on dialysis they give 180 points. So it's a very odd system. I don't know how they have come to develop over a period of time. I'm sure they would have looked at the outcomes, and a lot of more statistical people, more well read than us, would have probably looked into it and come to this conclusion.
Maybe like to make
Things more complex, yeah. So ultimately, the points are same, and there's something called a UK pancreas fast tracks scheme, that if the pancreas is being declared unfit while it is being retrieved, or if it's been declared unfit by more than 4 centers, then they probably would allow the center which is nearest to be used right away. And there is an allocation priority for patients, that you prioritize the liver and pancreas patient first, then the intestinal transplants first, and then you come with the multivisceral and the multiple organs. So coming to the US, I think the points are almost the same HLA, blood group, waiting time, proximity. The extra things here added are the pediatric. I don't know how many of pediatric patients would actually need a SPK or a pancreas transplant alone. And there's a prior living donor priority. Again, that's a query. How many actually would actually need? And SPK are actually ranked ahead of the pancreas alone or the pancreas after kidney. So 50 years old, BMI of less than 30 goes to the whole organ. The rest goes to the islet cell. Of course, centers are given a choice if somebody wants to take a more, has a higher risk appetite. So yes, is okay to use that organ even if it is older than that. So this is the older classification which was there in the US, and things have changed now that they had the criteria was based on these three categories: the candidate's biology, patient access, and the feasibility of doing within the certain period of time. So they had this geographical 250 miles mark that okay, in this region only we will use these pancreas. So that was categorized. So now they have changed that to a more of a continuous process that you actually use a composite score rather than an individual category, right? So you're not going to use that in I mean, even if your pancreas is going outside that, it's all right. So but if you have a continuous scoring, so for candidate biology they take blood type and the CPRA. So obviously if you have high CPRA, you get a higher points. And then prior living donors, pediatrics, and the waiting time are the patient factors, and the travel efficiency, and the proximate, how close are you to the organ where the organ is getting procured. So all these are put into composite score, and then the allocation is being done rather than the earlier system of having categories. So fairly complex. I again tried to look at a simpler option, so I found that the Australia is probably better than that. But again, I mean, the scoring system again is very confusing here. Like they give base score of 80 lakhs or what, I don't know why they have to give 80 lakh score, I don't know. So but there is a national priority bonus that if somebody is highly sensitized, had a complete match, then it overrides the distant criteria. So wherever the organ is, just flies to that particular person. So that's the match level one. So first is the national matching. So any patient who's completely HLA matched, sensitized, they get the first priority. The second is for somebody who's has for the standard pancreas, the PRA more than 75, but not a complete match. So they then get the nearest regions they get. So they divided that Australian region into different based on different centers. So they get the second priority, and the third is the standard one. So, but why they have kept this scoring system of 7,000 and 5,000 is just. So where are we in India? So India, I think the guidelines have been in evolution. So have had multiple meetings starting from 2016. The last minutes were circulated in 2023. They were semi-final, and we had a meeting I think a couple of months back, but we haven't had the minutes of that meeting. So we still, these are the national guidelines. Of course, the state guidelines do differ. So this is what we got at the last minutes, that pancreas donor should be less than 55 years, BMI 30, of course non-diabetic, no history of alcohol abuse, so that's very subjective. Donor hyperglycemia is acceptable at the time of ICU admission, HbA1c of less than 6.5, and these tests are required for all donors. So whatever how you interpret is up to you, but you have to have a serum amylase and lipase for all donors. SPKs get preference, and they wanted that the type 1 should get a preference over type 2. So how do we decide about that? That's a very gray area. If you start preferring type 1 over type 2, type 2 will never get a chance, right? So you have to have some scoring in place, which we still, I don't think any of our organ systems have a scoring in place. And of course, the waiting time is the only criteria we have. Again, for PAK and PTA, so type 1 gets a preference over type 2. Listing criteria, what was mentioned was GFR of less than 30, but I don't know how many centers, I mean, can we have a show of hands? How many centers actually are following this EGFR? And I don't think anyone would be able to do a pancreas transplant without the patient being on dialysis. Less than 20, okay, right. Yeah, so we have not been able to do any, so all patients have been on dialysis.
I mean, the UK changed its criteria. It used to be less than 30, and Anil would remember that we've done pancreas transplant on people with a creatinine of 180. That is the British remodulated back to 20. But even we do not get as many patients who are pre-dialysis. And as Anil said, we are so reliant on verbal patterns.
Yeah, and then the listing criteria for PAK, PTA. So the same what we have been discussing, and except that you have a pancreatic exocrine insufficiency added to the list. I don't know, has anyone of you done a transplant for pancreatic exocrine deficiency? So just to so just to clarify, like in pancreas exocrine insufficiency, we do have a lot of patients with pancreatitis. So I do get referrals. So those patients will be on enzymatic therapy, which is very expensive as per the Indian standard. So cost about 15,000 per month. Even with that therapy, they are not able to maintain their weight. They are malnourished. So those patients we have put them on the list, but so far we've not been able to transplant any of them. Some of them do have diabetes as well, but some are euglycemic, and they have not had a pancreatectomy so far. As high as possible in the jejunum, yeah, but not. I mean, the literature says that you can put in the duodenum also. So, but
Give allowance for the fact when you come back and take it out, you've got a bit.
so what are the challenges we face? I mean, like the biggest challenge I think what we the kidney is not following the pancreas. I mean, all developed countries that's the norm. So kidney is not allocated till the time the pancreas is refused. So we are wasting so many of healthy pancreas, 1,000 donations, but no allocation is happening, right? And I mean, no attempt is also being made to allocate these organs. They are not even offered to other states if you are not being. We've tried to prick and push a lot of centers, so then you start to get some offers, but they'll come in the middle of night, 12 o'clock. Karthik is here, he'll just send me WhatsApp at 12 o'clock, sir, I have a pancreas at Hyderabad, please take it. Healthy pancreas, 20 years old. But then when you ask for retrieval, sir, retrieval will start at 5 o'clock. I can't fly. I can't get my patient and fly and take the organ back, and so right. So maybe we now have the normothermic machine system. So we've started doing with the kidney. So probably put the pancreas on the machine and then maybe sort it out. So that's yes, that's a possibility we've been considering now. But still, you have to get the patient, the donor blood, the CDC cross match. So all those logistics. But you still need donor HLA. I don't think they'll do a donor HLA for me free of cost.
So,
So those are the challenges. I mean, I'm sure we are working on it. We'll probably be able to find solutions. We've used over outstation pancreas now. We've got from Delhi, we've got from Rishikesh, and we got from Rohtak, I think, and Panchkula. So we've started using them. So hopefully we'll be able to start flying and use. So final thoughts. I think no donated organ should be wasted. We need to have more such programs in the country. At the moment, I think I see only 4 or 5 centers which are actively doing it, and we have a huge population which we need to cater. We need to develop the allocation systems which should be patient centric rather than hospital centric. And it's not for pancreas, it's for other organs also, right? I mean, it's absolutely makes no sense that you are having a rota system of organs. Okay, one organ next time, now it's going to Apollo, next time it will go to Max, then go to Fortis. I mean, what are we dealing with? We're dealing with human patients. It has to be a public property. It cannot be a hospital-based allocation policy. And then we have a public system and a private system. One organ, one kidney will go to the public, and so the organs retrieved in the public will go to the public, and private will go to the private. So what is this happening here, right? So somebody has to have a common sense and work on it, and then you have a state and the national thing. So there is no national property here. So whatever is there in the state is utilized in the state. Even if you have the HLA matching and also no consideration is that. So we probably need to correct all this. And then there's a belief that if you're giving a priority to SPK, you are just giving diabetic patients putting on top of the list. So the nephrologists are very skeptical. That is why they don't refer the patients, right? So they think that it's just overriding the waiting list. And can we have a payback system? So we've been asking for that. Okay, you plus give us kidney and pancreas, we'll return the kidney to you at a later stage. So some things of that sort, if we can develop, probably we should be able to do a better job. Thank you very much.